everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today I have yet another special guest. So every once in a while, I find a PEM physician or any physician who's been practicing pediatric emergency medicine or medicine long enough that he or she have rules of their own. So a few weeks ago, I communicated via email with Dr. Carla Laos, a pediatric emergency medicine medical director here in Las Vegas, who I work with sometimes, and she wrote something in her email that really attracted my attention, and after having a close discussion, it became clear that obviously, like many others, she has her own PEM rules. So I decided to bring it to the podcast, ask her about the rules that she has, and ask her opinion about some of the rules I have, and hopefully we can learn from one another. So welcome, Carla, to the show. Thank you very, very much for doing this. Apparently, Carla had a very rough night in the PZR, and she's still here. It's 8 o'clock in the morning, so I appreciate your time. And let me just introduce you. Carla, the only thing I don't have is you're originally from...
So born in Brooklyn, New York, but have lived most of my life growing up in Texas, Dallas, Texas.
All right. So originally from Brooklyn, New York. You went to medical school at Ross University School of Medicine. Followed that, you went to Florida for residency. Is that right? In Jacksonville?
That's correct. Yes.
Which is a place I know very well because I used to be in Orlando for a while. And then, like me, she was super lucky to get a very, very good fellowship in a very good place named Texas Children's. So excellent training. I know currently, Carla, you work as the medical director at St. Rose Hospital Pediatric Emergency Department, which is a hospital that we work kind of closely with, transferred to each other. Anything else I forgot in your resume that you want our PEM Rules listeners to know?
No, I started my directorship career in another pediatric community setting in Austin. So the second pediatric ER in Austin opened up. And I was fortunate enough to kind of, hone my skills there for about 4 to 5 years. And that was St. David's in North Austin. And so that was a really great experience.
Very nice. And Austin is a nice place to live, I heard.
Yes.
Yeah. So, Carla, first question I'm going to ask you. I ask all my guests that, and it's always interesting to see everybody's answers. What is your definition of a good PEM provider? One who does what?
For me, the definition of a good PEM provider is someone who knows how to simultaneously unify and lead the team around a child. I just honestly believe wholeheartedly in interprofessional collaboration. And I think that if you have a healthy culture with really great communication, the kid is who benefits the most, and that child will also benefit in a fast way.
Very nice. And I guess that takes me to what I was going to say next is the reason I invited Carla to come on the show is because a few months ago, we were communicating about patients or something by email. I honestly don't remember. And you replied back, I quote, "Kids do better when we hold hands around them." And I thought about it like, oh, wow, that sounds like a PEM rule I can use. So I contacted Carla and I asked her if she has more rules like that. And that's when the conversation started. So tell me, Carla, where did you hear that? Did you come up with that? What does that rule mean to you? Kids do better when we all hold hands around them.
Yeah, so I think it has evolved. I came up with that saying off the cuff, I think because I could see what we were trying to do at the time, and that was do a better job of connecting across a city where, in Las Vegas, things tend to be fragmented for pediatric care. And all of the pediatric emergency medicine physicians, remembering our field is just barely 30 years old, come from huge centers where we see it's almost what I would call an orchestration of resources and people and various healthcare team members that are all channeled and focused in on the same goal. And when you are out of that setting, I feel like there's a big responsibility we have as pediatric emergency medicine doctors to either recreate that or try to get every other place, right, in the United States and potentially the world to function in that way. And so I think that kids will do better when we all hold hands around them. I can sit here and work in a community pediatric ER and complain about what we don't have, right? I can listen to a burned out nurse or a really tired tech and hear a sarcastic comment or just something that's letting me know how they feel. Or I can turn it around and focus on what we do have. And there are so many, just countless examples of that, just that I have found in my journey as a medical director. And it's a matter of connecting the dots. And if you can remind people just something little like, hey, I actually can't do my job without you. If you can create a culture where you recognize maybe that someone is burned out and then you get them to turn on their skill, right? Their superpower. If you can make everyone feel that their contribution is valued, what happens is you turn around the culture. So now people are coming to you around that child to contribute something. Hey, when I was doing this EKG, I noticed this. Can you come in? The nurse might say, it seemed like something was off. And but we all know this. When you see the strong, experienced nurse walk by, right, and ask for help, just calmly, hey, can you meet me in room 1? You immediately get up and you go. Each person of the healthcare team really just wants to know that their input is valued. The opposite of that would be a culture where no one is communicating. Everybody's just trying to get through their job and something's going to get missed because they either feel like they couldn't communicate, they felt like they were going to get blown off. So it's a very both simple and nuanced, if that makes sense.
Yeah. No, I think that's actually a very good comment. And I like what you said about, identifying that burned out person and give them a hand, because once one chain in the link doesn't work, then things get a lot more complicated. So certainly if we can help each other from the tech to the attending,
right,
things work a lot better. And it doesn't surprise me that you recognize that as a leader and as a director. And that's obviously an excellent skill. I'm going to ask you to elaborate on some other things that I heard you say. Is that okay?
Sure.
So I don't know. I guess you wrote this to me. If you took the time to criticize or judge, you have missed the opportunity to teach or coach. Where did you hear that? What is that from?
So that is another quote that I came up with when I was in my first directorships, my first 4 to 5 years of directorship in Austin, Texas. And one of the things I noticed was it is so easy to point out the negative things. So when EMS would come to drop off, and try to give us handoff on a patient, they would leave. And then I would hear chatter, whether it was physicians in training or nurses or techs, make some kind of comment about what was done wrong. And I realized immediately it was bothering me, but then I sat with it and asked myself, why is it so, what is going on here? And then I'm a huge fan of EMS, huge. We partner with them, anywhere that I'm a director, because I feel like they deserve so much respect for what they do. They do a lot of what we do in a shorter time period in a totally random location and then on a moving vehicle that is super tiny. And then they come to us and, 9.9 times out of 10, the child is improved, stable, and we have a general picture of what's happening. So through our partnership, I was realizing, wait a minute, we are the experts. We are the ones that see kids all day, every day. Anybody who works in a pediatric ED, anybody. And therefore, it's actually just our responsibility to, if we are the experts, it is on us to figure out how to make that quick exchange, the EMS handoff, a good one. And then I was challenged, right? How can I turn that quick time into, are we having a good exchange? And is there not just a one-way giving of information, but can I, in a positive way, turn that into an exchange where you, as the EMS person, feel like you can ask me something? And it's worked, right? Like, hey, you did a great job. That's awesome. Did you know? And then I might drop a PEDS nugget, right? For tachycardia, here's what our norms are. We then did something like we made badge buddies with pediatric vital signs from Harriet Lane. and handed them out to EMS, right? So that it's a small token, but it's also saying, I see you, and I know you know adults like the back of your hand, and that children you don't see as much. So here's something to just open up the dialogue. And then you start to get questions. Hey, doc, what do you think about this? Hey, doc, what would you do next here? Hey, is there anything we could have done better? Or on my end, you have to maintain that, right? Oh, let me give you a PEDS love nugget, is what I call it, right? Because immediately, if you're saying that, it sounds silly, sure. But what you're saying is how I'm going to give you a piece of information in a non-critical, non-judgmental way. And if you can do that, the conversation just blossoms. And what really comes out is they want to learn about children, and they want to be able to do a better job, and they want to be more comfortable. But they can't do that if they don't feel like, number one, they're respected, that they have space to openly communicate, right? So I'm a huge fan of protecting that EMS timeout. And I will say to everybody in the room, nope, we're going to wait till we get the child over. And then, this is the person documenting, and, we want to give you full time on your EMS timeout. Right. And so that is where that came from. If you took the time to criticize or judge someone, that is such a precious, valuable amount of time. And to do it after they leave means you have missed that chance to help them be better, be faster, be more accurate, give them. They don't have time to read all of our evidence-based medicine that constantly keeps changing on our field. We barely do. And so if you do that, then it's an open dialogue each time, and each time it's better for the child. So that's where that came from.
That's excellent. I love that.
Mm-hmm.
I love that. I think that's a great rule. I could not agree more about EMS. I think personally, my eyes kind of opened during my EMS rotation fellowship in Pittsburgh, where I learned those people make so little, and not like you said, like they do a great job 95% of the time, and they make our job easier. And many times we take the credit, or they're nowhere to be found to get the credit too.
Right.
So yeah, I could not agree more. I completely agree with the timeout. Something that I also try to do, give them the respect. They did what they did. They came in, let them be the practitioners that they are, and give a sign out. Everybody should respect that and be quiet. So I could not agree more that this is, I'm so super glad you're saying that. That's excellent. Shout out to any EMS provider who wants to come on the podcast and talk about that. FYI. So Carla, last question, and this is actually the first time I'm doing it on the podcast because your content and your rules are so good. I'm gonna take one of my rules and turn it to you, and I'm gonna ask you, what do you think that means, and what does it mean to you? So when I started this podcast, I started it based on rule number 1, which was hammered to me by my mentor Rick Saldino, who's been on the podcast before, and he used to say all the time, it's not the patient's job to prove that they're sick. It's your job to prove that they're not. What does that mean to you?
The first thing I think of is how that translates to the family, right? An example would be a child comes in last night, called in by the pediatrician. This child was seen in your ER Sunday, which we hate that saying, right?
Right.
Because your first thought is, what did I miss, and is that child okay? But it was, everything happened right. Our doctor treated that child well, maybe did some viral tests, even though we know that it may not change our management. The parent was very insistent. Sometimes there's a newborn at home, sometimes there's a 70-year-old at home. Testing was negative, child was observed, sent home. And this is evolution of disease. We always give, anticipatory guidance on when to come back.
Excellent.
Child follows up with pediatrician. Yes, that's a win. That's what's supposed to happen every time.
Yes.
So pediatrician calls and says, hey, we saw them yesterday, still febrile, but looked good. And then we got a call today that the child is having labored breathing. So now the child has had fever for 101 for 4 days. I'd like them to come back because I'm concerned about the breathing. It's obviously after 5. They trust. They're trusting us again, right? I can choose to roll my eyes. No, I hear your concern. You're worried. You can't see the child. You can't examine the child. You last saw the child and they were fine. We do our testing evaluation, H&P, child ends up with a bilateral pneumonia. To your point, it's something that's we would call it simple. The child has a bilateral, patchy infiltrate, but oxygen is fine. rest of the vital signs are fine. Child was febrile and they came to us. We gave antipyretics. We watched them defervesce, vital signs normalize, all this stuff. Thank you, fellowship. And it was one of those things where when it comes to flow through the department, I was like, let me go ahead and get the discharge papers ready. It's after hours. Do we need to give the first dose of antibiotics? Probably. You're always thinking of how to make the parents one less step, right? We can give the first dose of antibiotics in the evening. They can go home, sleep. Somebody can pick them up in the morning.
Absolutely.
So I was sewing a child and had everything prepped. And sometimes the nurses are faster than I am. And so they went into the room with the discharge papers. And you try to leave, you try to communicate. You can't find the nurse. You leave a note in the comments, maybe on the tracker, pending MD recheck, which for me is like, hey, I need to go back in there. So I come out of the laceration. I'm sewing up. Nurse is like, hey, mom wants to talk. She said nobody circled back with her. And I was like, oh my gosh, absolutely. You're too fast. You made it before I did. Walk into the room, immediately service recover. I'm so sorry. Sometimes our nurses are great, right? And they just beat me. They're so fast. Always manage people up. Always manage your team up. So I sit with them and they say, they're so worried because they're like, is this normal? Is this normal? Is my child going to be okay? Is this serious? And you have to remember that we take for granted what we see every day in and out. And immediately we're always like sick, not sick. And to your point of needing to really you need to prove to yourself using all the skills and education that you have as a PEM physician, that they don't have something serious that's going to hurt them or that requires another, consultant or requires admission. And so I love the art of consolidating all that information and walking into the parent. And because a lot of times, we know that I can't tell you what it is. And I know that's hard. I know that's hard as a parent. I wish I could give you the answer every single time. But I'm going to go through all these labs and all these pictures, and I'm going to tell you what it's not. And for pediatrics, a lot of times that is what we're focused on. I need to make sure it's not the heart. It's not the lungs. It's not the kidneys, the liver. It's not anything that needs surgery. And as you walk through that conversation, you can see the tension drop in their faces. And you simultaneously are seeing that they need to be validated. And by the way, you did everything right. You did everything right. Your pediatrician did everything right. So for this child, we had an answer, right? But it still is scary for them. And it's this art of knowing how much information to deliver. Do I need to talk to them about a complicated pneumonia and effusions and VATS and, surgical procedure? No. Yeah, your child does have an infection in the lungs. They may have started out with a virus, right? And it worked its way down into the chest. And then, their immune system is still developing, right? The child was 1. And so it's nothing that you guys did wrong. And so this is what we look for. You guys were right to pay attention to the temperature and that something was off. Listen to that. And then, I tend to make sure they have copies of the imaging report. And because I think that's just something tactile. And then, the labs are all included in the discharge and that can go. And the pediatrician, it helps the handoff, right? Because a lot of times the parents are so stressed, they don't remember that we talked to them, right? Or they don't remember that they saw someone. There's so many people coming in and out of the room. So for me, I love that saying. You're absolutely right. It is on us to make sure that it is not something more severe. It is on us to be certain enough that we are comfortable with sending the child home or that we've done everything we can to ensure, I love the image of the 4x4 Olympic, relay, that you have passed the baton, this precious child you don't want to drop either to the pediatrician or to a close follow-up with a specialist. So yeah, hopefully that answered your question, but I love that saying.
Thank you. No, I can't take the credit for it, but I agree. And I love what you said about the parents and trying to tell them what it's not. The way I explain it to the residents and the fellows is we're not in the business of winning. We just don't want to lose.
Right.
You send home a child with abdominal pain. Turns out that it's appendicitis. You lost.
Right.
You send home a child with abdominal pain from constipation. You didn't lose. The child likely is going to be okay. So yeah, I like what you said. And it's very evident, Carla, and I kind of knew that from before. You're clearly very passionate about pediatric emergency medicine, which is why I wanted to have you on the show. So thank you very, very much for your time, and thank you for the amazing job you do with the children in Las Vegas, which is a huge challenge, especially in the community. I guess I have to honor you with an outro, and your choices were super rough. You actually want me to play Jimi Hendrix. You think I can do that?
Every confidence in you.
All right. So we're going to do, I guess you like Jimi Hendrix, you like John Mayer, all those really, really good guitar players. You like blues, I guess, also, you said? All right. I can work on some blues. I've been working on my blues soloing skills.
Excellent.
Carla, thank you so much for coming on the show. And again, thank you for all the great job you do in Las Vegas, which I super understand is very challenging. I happen to know many people who work with you. They all have always great things to say. So thank you from the bottom of our hearts. And thank you for coming on the show. And thank you for what you said about EMS. I could not agree more. Shout out to EMS who want to come on the show.
Thanks for having me out.
Thank you. And that is it for today, guys. Thank you very much for listening to Carla and her wisdom. Thank you for checking PEM Rules, checking the website and the Facebook page for all your comments and support. I truly, truly appreciate it. Carla gave me one of the biggest challenges I've gotten on PEM Rules. She actually wanted me to play Jimi Hendrix. Now, Carla, I'm going to be very honest with you. I literally Googled what's an easy song by Jimi Hendrix, and I found this one. This is called When the Wind Cries Mary. Hope you like it. Thank you very much.